Diabetic macular edema remains the most common cause of acquired visual loss in the working age population in developed countries. Now, historically, we had access to macular laser treatment, which could slow down the rate of visual decline. But there's been a transformation in the last decade with the advent of intravitreal steroid and anti-VEGF agents. In clinical trials of anti-VEGF agents against macular laser, for example, DRCRnet Protocol I, Vivid and Vista clinical trials, and the BOLT clinical trial, there have been impressive gains in visual acuity in the anti-VEGF arms compared to macular laser. There is strong clinical trial evidence for benefit with anti-VEGF agents. However, we do have to remember that there's a frequent need for intravitreal injections in the region of 8 or 9 injections in year 1, 4 or 5 injections in year 2, and less thereafter. And so we have to bear in mind this frequent need for injections and whether our patients can maintain that kind of regularity of follow-up. The other area of concern is the risk of systemic side effects. A Cochrane review identified that in the medium term, there is unlikely to be a significant increased risk of death or stroke in patients included in pivotal clinical trials for anti-VEGF therapy. However, they did comment that high-risk patients, for example, those who've had a stroke or heart attack in the last 3 to 6 months, were excluded from these pivotal clinical trials, and further data is required in these populations. So we tend to use intravitreal steroids in patients who are either pseudophakic or in whom we're planning cataract surgery, because we know that intravitreal steroids can be associated with cataract progression. In terms of clinical trial data, we do have evidence from the Bevidex clinical trial, which was a trial of bevacizumab against dexamethasone implants for center-involving diabetic macular edema, carried out in Australia, with the principal investigator being Professor Mark Gillies. And that showed that if you look at the subgroup who was pseudophakic at baseline, you could achieve very similar visual outcomes at 2 years with the 2 treatment arms. It should be noted, however, that about a third of eyes in the steroid arm required topical IOP lowering drops over the course of the study. So we tend to think about using intravitreal steroids when either anti-VEGF agents are unsuitable or not sufficiently responsive. Now, in terms of unsuitable, the most common reason would be patients are unable to achieve the frequent follow-up needed for frequent intravitreal injections with anti-VEGF therapy. The other time that anti-VEGF therapy may not be suitable is a patient who's had a recent stroke or heart attack, and I discussed the option of intravitreal steroid therapy with these patients. In terms of insufficient response, we do know from data from RISE, where if you look at giving intravitreal ranibizumab monthly for 2 years, approximately 24% of patients still had persistent macular edema. So we do know that some patients will not get complete anatomical resolution with anti-VEGF therapy. There's some debate as to when is the best time to consider switching to an intravitreal steroid in these patients. There's real-world data to show that clinicians have considered switching between 3 and 6 months, but there is a lack of clinical trial data in this arena. The other time that we may consider that intravitreal anti-VEGF therapy may not give us the response that we're looking for could be in vitrectomized eyes, and there may be an argument for using the advantage of the stable pharmacokinetics of a steroid implant in these eyes.